Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. Hemorrhagic strokes cause bleeding and swelling of the brain and are responsible for 40% of all stroke-related deaths. But there's a new treatment available that can help reduce that number. It's called an irrigating intracranial drain. Dr. Nicholas Brandmeir, neurosurgeon at the WVU Rockefeller Neuroscience Institute, was the first in the world, yes, I said first in the world, to successfully perform this procedure. He's here to tell us about that and more. Welcome, Dr. Brandmeir, to Tuesday Talks.
Welcome, thank you.
It's good to have you. Now, we encourage you to post any neurosurgery questions you may have in the comment section below, and we'll try to answer them live the best we can. Okay, so back in March, you were the first in the world to successfully treat a hemorrhagic stroke with an irrigating intracranial drain that provides a therapeutic approach to relieving intracranial bleeding. I hope I got that right.
Yeah, that's all.
All right,
that's all.
good.
Sounds great.
So before we talk about that, tell us first about what is a hemorrhagic stroke.
Right. So that's a great question. So oftentimes we hear about stroke, and all the things we focus on stroke, we're really talking about a condition called ischemic stroke, which is a very different condition than hemorrhagic stroke. So ischemic stroke, it means that the blood supply to the brain has been cut off and that no blood is going from the heart to the brain.
Okay.
That's what we typically call a stroke.
Okay.
But really what a stroke means is any time where your brain stops functioning all of a sudden. That's why it's called a stroke.
Okay.
So there's different kinds of strokes. And so a hemorrhagic stroke would be, rather than the blood supply being cut off, something happens where you get bleeding inside the brain itself. In the same way you'd have bleeding in the liver, the stomach, the foot. You get bleeding in the brain, and because that blood can compress or injure different parts of the brain, it causes a stroke, and that's what's called the hemorrhagic stroke.
Okay. And that leads to brain swelling as well?
Right, and so that leads to a whole host of issues, including brain swelling, direct brain injury, building up of fluid in the brain called hydrocephalus or water on the brain, and just irritation and dysfunction of the brain tissue itself because it's near all that bleeding product and stuff like that. And so, that's how it causes a stroke, for sure.
So how are hemorrhagic strokes treated, and what's the success rate of that treatment? How are they usually treated?
Right. So, it's important to know that we've got, stroke is always a very complex topic. And so when we talk about hemorrhagic stroke, there's many kinds. The most common kind would be from having high blood pressure. Your blood pressure gets too high, you have a hemorrhage in the brain. And another common cause would be like a ruptured brain aneurysm. So you have an aneurysm or weakening in the wall of the blood vessel of the brain. It ruptures, the bleeding goes into the brain, and so that's what people, the technical term would be hemorrhagic stroke, but oftentimes we call those aneurysms or brain aneurysms.
Okay.
So that's really what we're talking about. And usually the way we treat those in the past, especially the kind due to high blood pressure, is we just control the blood pressure and then we wait, because nothing that we've tried has been shown to improve length of stay in the hospital, length of stay in the intensive care unit, improve survival, anything like that. And we know that the longer patients are in the intensive care unit, the longer they're in the hospital, it's because they're sick, and so they're at risk of all these complications that prevent them from an eventual good recovery, pneumonia, whatsoever. So the goal really was what we were trying to do with hemorrhagic stroke, because of course once the bleeding's happened, we can't go back in time. We just have to deal with the blood that's there. Is that instead of simply waiting for the body to clear the blood and the blood products on its own, we can now speed that process up by sometimes as much as 10 to take what would be a 2-week process and make it like a 1 to 3 day process, by instead of just waiting for the body to absorb it on its own, to actually wash it out in a safe way. So that's kind of like how the treatment is. And that's how we deal with the blood in the brain. Now there's a whole host of other things that we need to do at the same time.
Right.
Prevent the bleeding from happening again, make sure that the patient is taken care of from the standpoint of their lungs and their heart and all that. So we're kind of doing a whole bunch at once. What's new about this approach is that instead of just waiting for the blood to go away on its own, we can actually speed that process up, speed up the recovery.
Yeah, how does this drain work? Because it does, because before, if I understand correctly, it was just like you were just basically using gravity for it to drain. But now you're kind of helping it along.
Exactly. So, I think that's exactly right. So the technology that has been the standard since the 1800s, early 1900s has been to put a drain in, and then you just let gravity drain the spinal fluid alone away, because the blood doesn't really, it's thick. And so it won't go through a drain, at least a drain the size that you would want in your brain, right?
Right.
So how do you get that blood out of there? It's been a very difficult problem. And multiple avenues have been tried, including open surgery with, or putting medicine in through the catheter, and they've all had limited success up to this point, because either the surgery itself was very difficult to perform, very morbid, or you only did it in the worst of the worst. And the gravity drain, air, blood, anything would get stuck in it, and then the drain would stop working. And so then so you had to be very careful to keep the blood out of the drain, that you can keep the spinal fluid going. What this technology, the continuously irrigating ventricular catheter, what it allows us to do is it allows us to, in a safe and controlled way, actually irrigate water or saline or medicine even into the brain, and then make sure that we're getting the correct amount of fluid back out, and without the brain pressure going high, so we can kind of irrigate the fluid through the brain, wash it out in a safe way. We could always irrigate it through, but we had no idea how high the pressure was getting, what was happening, and we only had one pathway. So if you were irrigating in, nothing was coming out. Now with the new one, you can irrigate in, measure the pressure, make sure the pressure's not getting up high, and while it's going in, it's coming out at the same time, so that fluid doesn't build up in the brain.
So you have a lot more control.
A lot more control, a lot more accurate, a lot more scientific, I would say.
Okay. Now, I read where the drain provides a therapeutic option called the active fluid exchange.
Right.
Is that what you were just describing?
Exactly. So active fluid exchange is we're actually, just like you would with an IV, we're actually providing medicine. Now, sometimes it's just fluid that's inert, sometimes it's fluid with medicine in it, and then so we're kind of in with the good, out with the bad, just like you would want with any other collection of fluid that you have in your body.
Sure. So would you consider this a game changer in the treatment of hemorrhagic stroke?
I mean, I think so. I have to be careful and say that it's FDA-approved therapy for this, but the clinical trials that show massive improvement aren't done yet. We're a major center at WVU, other centers all over the world who are also, with us leading this technology forward. So we're eagerly awaiting those. But what I have seen in my practice and what others around the world who are using this new technology are seeing is that strokes that would have been in the intensive care unit waiting for that blood to clear, sometimes 10, 14, 21 days, we're reliably seeing it clear in 2, 3, 4 days.
Oh, wow.
So from that standpoint, when you've been doing this for a while and you've seen many patients and you know how they're going to do, and then something comes along that's, from my point of view, I do consider a game changer, but I do want to be clear, that evidence from the clinical outcomes isn't out yet, but I don't think many of us expect that it won't reflect what we're seeing in our practice. But we're just waiting for that data to come out.
Is it too big a leap to say it's saving more lives?
Oh, no, I absolutely think it is.
Okay.
And I think there's other, active fluid exchange opens a whole host of possibilities. So if you cast our minds back to the history of medicine, for a long time, the only way to get medicine was to take a pill, right?
Right.
And so if you take a pill, it has to go through your stomach, go through your liver, then get into the bloodstream, and then get distributed. And then we invented IV medicine, which goes directly in the bloodstream, and then goes to the rest of the body. And then if you think about it, when we talk about more newer therapies, so when we talk about treatment for heart attack, treatment for ischemic stroke, now we're putting the medicine in the artery. So instead of going through the vein and then getting distributed, we're going directly into the artery to the organ that's at risk, and only giving the medicine to the organ at risk, whether it be the heart or the brain. Now we can get into yet another even closer area. So instead of putting the medicine through the artery and hoping it gets to the brain, now we can put it directly in the area and safely give the medicine, just like, so it's kind of analogous to going from a pill to an IV. Now we're going from an IV to directly, safely giving the medicine to the brain in a more effective way.
Great. We have a question from one of our viewers. Women can present differently for strokes. Is that the same for a hemorrhagic stroke?
Yeah, the hard thing about stroke is that it can be difficult to suspect, and so you have to have a high degree of suspicion. And I think if you know that a stroke is potential, say somebody comes in with a severe headache, but no other symptoms, and if we're talking about hemorrhagic stroke in particular, say severe headache, high blood pressure, but otherwise is fine, well, you have to think, oh, I should get a CAT scan and make sure that they're not having a stroke.
Right.
And now, realistically, because hemorrhagic stroke is almost always accompanied by a severe headache and high blood pressure, emergency departments around the state, in my experience, have been very, very good about recognizing those symptoms and getting the CT scan. Now, of course, most of those CT scans are going to be negative, but you'd rather, have 100 false, like 100 negative tests to catch to one person with a stroke, so you can help them. But I have found that, especially here, in WVU Medicine, our satellite hospitals, people that I work with, it would be very unlikely that they would miss a hemorrhagic stroke of the kind we're talking about, because of that headache, high blood pressure kind of presentation.
Okay. We've got another question. Do you place the active fluid exchange system at the bedside or in the OR?
So it just depends on the patient. We've actually been a real kind of innovator, leader at the intensive care unit, in the neuro ICU, and at WVU, in that we bring technologies that typically were only available in the operating room to the bedside. And by that I mean we can, what we say, navigate, which is, instead of using anatomic kind of landmarks where we kind of look at the patient, measure, and then we just know how to do it in the same way that you know how to sew or throw a basketball. You're just relying on your hands and your skills and that kind of thing. We've brought computer navigation from the OR to the bedside, so we can take the CT scan, put it on the computer, map it up to the patient's head in actual real life, and then directly guide the catheter into the exact spot, knowing. So sometimes you have to put them in the operating room because you're doing an operation anyways, or whatever. Right. But what we try and do is do it in the bedside, because you're in the intensive care unit. You don't have to move the patient. It's safer. It's faster. Infection risk is lower. All these things are improved. And if we can using the modern technology, there's no reason to be moving the patient and adding all this complexity and uncertainty when we can just do everything right there in the intensive care unit.
Wow. Well, let's talk a little bit about the risks and benefits of this drain, this procedure.
Right.
What are the benefits? What are the risks?
So the risk, so we'll start with the risk, because the risk is actually identical to all the things we've been doing for 100 years. So you still need a small hole drilled in the skull. You still need the catheter or tubing to be placed through the brain into the fluid space, which is in the center of the brain. But you need that regardless, and that's the ventricular drain process. There's no way around that.
Right.
Now, like I said, with computer navigation, skill, improving technology, we make that safer, more effective every time, and I think active fluid exchange is part of that process, the latest and probably most important part of the process, along with navigation that we've had in a long, long time, part of that process. The benefits we've talked about, I think the primary benefit is the ability to give medicine. And we're focusing on hemorrhagic stroke because that's kind of the most common use of the active fluid exchange technology.
Yeah.
But in rare cases, you have people with terrible infections of the brain, say meningitis that can spread into the ventricle or something like that. So previously, they get two problems, say if you have ventriculitis or meningitis. You get water on the brain, or hydrocephalus, which causes the pressure of the brain to build up, and you get an out-of-control infection that you can't treat because a lot of the antibiotics we give in the IV or in pill form don't cross into the brain because the brain's protected from the bloodstream. And so with this technology, instead of having to give very high doses of antibiotics that could be toxic to your liver, kidney, whatever, and to get the doses into the brain, we can just give the antibiotics directly into the brain. While at the same time treating hydrocephalus. So what we've seen, and again, these are case by cases, but we've seen people, so to give you an idea, ventriculitis, even with modern medicine and a bacterial infection of the ventricle, with the best possible care, can have mortalities of 60, 70, 80% in academic centers. And we've had several patients, not only here at WVU, but at other places around the world that are using this technology, where the patients go home from the hospital using this technology. And so, for these conditions that didn't have a good treatment before, hemorrhagic stroke, intraventricular hemorrhage, which is the kind of hemorrhagic stroke we're talking about, ventriculitis or bacterial infection of the brain ventricles, it's been a total game changer. We're seeing results that we never saw using the older technology.
Wow, that's interesting. who's a good candidate for this procedure?
Right.
I mean, is it for everybody or?
Well, no, I mean, I don't think.
Not much of anything is.
Right, exactly. And I always say to my patients, nobody wants to see the neurosurgeon, and that's true. So you don't, in all honesty, you don't want to be a good candidate for this. But it's important to remember, as part of this talk, when we talk about stroke and recovery, it's important to know, and brain trauma and the other things we treat, if you work hard and provide good therapy and the patient's treated in the ICU, 60-70% of patients with a stroke will end up going home and having good outcomes. So it's not a devastating, incurable disease that we think of, but it does require a lot of hard work. So when we talk about a good candidate for active fluid exchange, first of all, the technology is new, we don't know. It could be better for every time that you would have done a ventricular drain in the past, it could be the case that the active fluid exchange should just replace it altogether, right? It could be. I don't know. But certainly there are use cases right now where we really see the benefit. And those use cases are infection, like bacterial infection of the ventricle or ventriculitis or severe meningitis, that kind of thing.
Right.
And hemorrhagic stroke, whether that be from an aneurysm or whether that be from high blood pressure, which are the two most common causes of hemorrhagic stroke that we see.
Now, I know it's still early, but do we have any numbers on the success rate of this procedure?
Yes, so, in our hands, and again, and around the world, because I talk to my colleagues from other leading universities who are doing this, and we kind of, compare, and I keep track of all of our cases, So our rate of fluid, so if you use a standard ventricular drain in hemorrhagic stroke, the rate of occlusion while you're staying in the ICU or the drain getting clogged is 70%.
Oh, wow.
Using active fluid exchange, it's under 5%.
Wow.
Right.
That's a big difference.
A big difference. And when you consider that a blockage increases your risk of infection twice as high, so your risk of infection is twice as high or more if you get a blockage, and it requires a backup brain surgery to replace that catheter.
Oh, boy.
And, everybody wants to minimize the number of brain surgeries they have, and that's important to us too, right? So if we have a technology that means that previously 7 out of 10 people would need a second surgery, and now it's 1 out of 20 to 1 out of 100 need a second surgery.
Wow.
That in and of itself is a major improvement because we take away all those risks that you get 2, 3, 4 surgeries. Risk of 1 surgery is very low. That's much better. So that's the biggest changer. And then there's the cases where you just, I can think of several cases off the top of my head where you just see an outcome that you never would have expected. Somebody who, one of the last folks I treated with this had a bad infection that stemmed from just a regular sinus infection, not to scare everybody, but like these, bad things happen sometimes. And using the older technology before we had this, a whole host of things in the ICU, active fluid exchange, brain oxygen monitoring, all the modern therapy we had, his mortality risk was 90% plus. And he left the hospital a normal person. So you just would not see that outcome. 5-10 years ago was not on the table. And so it's amazing how things like improve. So it's
looking good so far.
I think it's very clear. But like I said, the more impressive the clinical outcome, the less you need to study it, right? So if it improves your life expectancy by a month, you might need 1 million patients in that study, right? But if it takes a risk of catheter occlusion from 7 out of 10 to 1 out of 20, we probably only need to do it in 10 to 20 people to see the difference. Now at WVU, I think we're the busiest center in the world using this technology, I know, and I think we're well over 100 patients treated with this therapy.
Wow. The Rockefeller Neuroscience Institute, man. Now we have another question.
Okay.
And I think this is a little bit of an inside baseball question, but so you can help us simplify this.
Okay.
It says, what do you feel are the main benefits to directly injecting Thrombolic or antibiotic into CSF with the automatic irrigation?
Yeah, so
this is a different audience. This question's for a different audience.
I think so. But that's okay, because it's a good, so what they're asking is basically, typically, if a thrombolytic is like a clot buster, so the kind of poster child thrombolytic is TPA, or tissue plasminogen activator. So that's a thrombolytic. and an antibiotic are things like vancomycin, what have you, just regular antibiotics. So number one, thrombolytics, if you have a hemorrhagic stroke, of course the problem is bleeding, so it's like, why are you giving a thrombolytic? Why are you giving a clot buster? And the problem is that the bleeding stops very shortly. Within 30 seconds of the hemorrhage, usually the bleeding stopped. But then you've got all that blood in there, and it sits there inert, so you've got to get that moving. And so the thrombolytic, the only way to introduce thrombolytic to the blood that we actually want to get out is by doing it directly through the spinal fluid or through the catheter.
Oh, okay.
And so if you give it in the IV, it will never get to that blood that's stuck in the brain. So you get all kinds of complications, bruising, bleeding issues, what have you, and never actually accomplish what you want to do. So being able to break that clot up like we do for a stroke or like we do for a heart attack is impossible without this technology. So that's why thrombolytic is important. Now, antibiotics we talk about, for instance, if you have an infection of the spinal fluid, meningitis, ventriculitis, the way we treat that with antibiotics now is we give very high doses of standard antibiotics because we have to get the concentration so high that it overcomes the brain's ability to keep out foreign chemicals. And so by getting the concentration so high,
is that the blood-brain barrier?
That's exactly the blood-brain barrier.
Okay.
So and so you have much more risk for liver toxicity, kidney injuries, platelet dysfunction, so blood clotting dysfunction, all these things, C. diff infection because your dose of the antibiotic is much higher, right? So it's a lot of it's getting in your gut. So you have all these complications that are building up, but the actual therapeutic dose of the medication in the brain is highly variable and unpredictable. So you may not even accomplish what you're trying to accomplish, which is why those infections can be so hard to treat. And I know at the RNI, Rockefeller Neuroscience Institute, we do all kinds of work in breaking the blood-brain barrier. But the simplest and most effective way to break the blood-brain barrier is with surgery, by just doing a brain operation and putting a small, minimally invasive catheter in. Because that breaks it right away. And so then now we can do very small doses of antibiotic that have no effect on the kidney, liver, what have you. But the dose that the bacteria are seeing, which is what you actually care about, 10, 20, 30 times higher than anything you could accomplish, no matter how much you put. And so you can use a much smaller, safer dose of antibiotic, get much more effect on the bacteria and spare the rest of the body and get a much faster clearance of the infection.
Because it's getting where it's supposed to be.
Because it's getting exactly where it's supposed to be instead of having to go through the blood-brain barrier.
Wow. Okay, we got another question here. It says, what can you share about the medication concentrations so that the dose is appropriate for the irrigation rates?
Yeah. So, I mean, this is when you kind of get these new technologies, you have to do a lot of figuring out. Luckily, at WVU, we have like an excellent pharmacy department. So this is kind of an example of why you need all kind of pieces of the puzzle or links in the chain. You can't just be a neurosurgeon and do this. You need other people to help. So what we do is we know from past experience what safe concentrations are for these medicines in the brain. We know what's effective. We know the safety ranges. And so because of that, and we can control exactly how much is going in, we can just make the drug mix up. And so so no matter how we kind of adjust the rate, the dose that the brain or the bacteria or the clot is seeing is always appropriate, is always safe, is highly predictable, which is, like I said, a big benefit. So, for instance, if you give, say, antibiotic, because we've been talking about that, or any other drug, you give that, what you actually care about is what the concentration of that drug is in the brain. But depending on the individual patient factors, that's hard to know, and we don't measure that. It's very difficult to measure.
Oh.
Whereas if you just mix it in the fluid, then you know. I mixed it like this, the fluid goes in, that's the concentration in the brain. So it becomes very predictable, very safe. You know
more precise.
The precise number that you're getting.
Wow. Great to know. Okay, so tell us about how you became the first in the world to do this procedure. That's impressive.
Right, yeah, I mean, I think so. So it's important to know, the active fluid exchange technology I got introduced to at a scientific conference. And so it was very early in its development. So I kind of saw it presented at the conference, and I was, like most doctors, when they see something new, it's like, wait, does it work? Does this actually work like it's supposed to work? And they were like, yeah, it works great. We're looking for people to actually try it. I said, well, if this works, this is a total game changer. And so then this was in October of 2019. And of course, COVID happened March 2020. And so we had to kind of deal with the outbreak of the pandemic and going through that, and so that kind of slowed the process down. Eventually, and I think it's a big testament to how committed to innovation and new technology and helping our patients that the RNI is, the WVU is, even in the midst of the pandemic. Before Delta variant had gone through, we were able to get the device in because the case was obvious. It was like, look, if this works, let's try it. Let's see. It's certainly going to be no worse than what we're already doing, and we could help a lot of people. So we were able, during the pandemic, to bring that in.
Wow.
When a lot of hospitals were totally shut down and not doing anything.
Right.
But the sad truth is, and what we all know, 2 years down the road, is that just because we're having coronavirus doesn't mean that people aren't having
strokes.
And so we can't just abandon them. And and I think the people at the RNI and the leadership and everybody was really on mission. Like, look, we have an issue, we're going to deal with that, but we still have sick people with other things, we need to take care of them. And so because of that process, because we were able to get the technology in, get experience with it so early, and our results were fantastic, everybody was kind of committed, that we started using it more and more, and we got very experienced. And because we had a great pharmacy department, because we have such great, eager nurses, so, when our normal neuro ICU, to give an example, we had to use it to house coronavirus patients. So the neuro unit, where we take care of strokes, we had to move to a different floor of the hospital. But the nurses there, instead of being like, well, we don't do this, they were eager. They were like, no, train us. We want to do the best thing for the patient. So, when other hospitals maybe were like struggling to find nursing staff, struggling to do this, at WVU, our nurses were like, give us more to do, like, we're here to help. And so we were able to train a whole new floor of nurses on the technology, and now we can use the technology. You don't even need to be in the intensive care unit. You can do it because the nurses in the step-down unit took that upon themselves to learn how to do it and did a great job. So in essence, we were able to be the first to use the latest, greatest version. It's important to say we use the first in the world of using the newer technology, like the new updated version. So you're always improving, innovating, and the new version, the new technology has a lot of advantages over the first generation, just like it had a lot of advantages over the generation before. And I think when I don't want to speak for there's a lot of pieces in that, but I think when you look around the world, around the country, and scientific organizations, companies, other universities are looking for partners. Where do we send our stuff?
Right.
And they see that the RNI has committed personnel at the intensive care unit, in the pharmacy, in neurosurgery, in the step-down unit, in leadership, in the scientific areas. And they're like, well, this is a place that's going to use technology appropriately.
Right.
You do it safely, but also not going to ignore things that could potentially benefit patients just because they're new.
So you mentioned earlier that nobody wants to have brain surgery, but if you do, talk a little bit about why should they, you don't have to leave the region, you don't have to leave the state. I mean, talk about the expertise and the experience at the WVU Rockefeller Neuroscience Institute. I mean, it is out of this world.
No, I mean, I'm super proud to be a part of the RNI. I've been here for 5 years, so I was kind of here at the beginning of the RNI and have, watched it grow to what it is now and continues to improve. It's important to know that the quality of physicians that we work with all across the RNI, and I work with, I have a lot of different hats. So I work with our neurology department, I work in the intensive care unit, obviously I work with neurosurgery, epilepsy, movement disorders, pain, our pain group, our neuroradiologists who do a lot of work with our stroke. Everybody's uniformly excellent. The nurses are excellent. Operating rooms are excellent. And, I've been a lot of places, talked to a lot of people. I talked to my colleagues about active fluid exchange and like what they're doing. And we talk about what we're able to do at WVU, and they're astounded.
Wow.
They're astounded. They're like, we would never be able to do that. We would never be able to put this drain in and have nurses competent and safe to care for them in the step-down unit. Like, they would be stuck in the intensive care unit. And at WVU, you're pushing the boundaries. And so I think it's absolutely the case that the expertise and the quality of the physicians and the staff all across the RNI, whether that be neurosurgery, neurology, whatever, is second to none. And I'll tell you a personal story, regarding that. I had a close family member who had an acoustic schwannoma, which is like a benign brain tumor, but it needed treatment. You know, you lose your hearing. And they live far away, and you know, they asked me, like, where should I go? And I was like, look, here are some good places, but you know, we're happy. You know, if you want to know, like, you can come here, and you know, my partner will take care of you, and we'll get that taken care of. And they came, you know, hundreds of miles here, and they were like, they said everybody they met here, you know, they've been to see doctors in Boston, their hometown, wherever, and they said this was the best experience that we've had, you know, dealing with this. And I hear that from my patients who've been all over, you know, the bigger cities around the area, Cleveland, Pittsburgh, whatever, they come to see us. You know, I saw a couple today, you know, like, we've been in 5 hospitals the first time we've been able to, like, find out what's going on and stuff. And so, you know, I really think that the R&I is really, like, the top quality place, and certainly there are many other great places to go, many great hospitals in the United States, in the area, but I think that R&I is among the very, very best.
It's the leader in the field, isn't it?
Yeah, I mean, absolutely. When you look at, you know, what I do with intensive care and neurotrauma or stroke from the intensive care unit, or you look at functional programs like deep brain stimulation, the focused ultrasound program, if you look at, you know, what we're doing with brain tumor treatment and stuff like that, like all up and down the board, we have world-class faculty who do amazing things. So
yeah. Well, we've outlasted the rain and the thunder. So before we leave, I always want to ask, what is the most important thing you want our viewers to know about this procedure? Yeah,
I mean, I think the most important thing I want to know, that I'm super passionate about because I spend a lot of time in the intensive care unit, spend a lot of time dealing with sick people, is that patients with neurologic injury get better. And it's important to know that. So if you have a stroke, unfortunate, if you have a traumatic brain injury, obviously these are terrible life-changing events, but it's not the end. If you get top quality care, top quality intensive care, top quality rehab, you work, you know, the vast majority of these patients will have a good outcome and go home. And so I just want to encourage people that, you know, we all have terrible things happen to us or our family members, unfortunately. But there's hope. The treatments work, and you know, if we can get to people in time and give them the chance, the benefit of like top quality medicine, they can get better. And I think that's the most important message.
All right. Thank you so much. A lot of good information, and you've given us hope, too. A lot of hope today. Thank you for that.
No problem. Thank you for having me.
That brings us to the end of this edition of Tuesday Talks. If you're looking for more information about this and other neurosurgical treatments, visit wvumedicine.org/RNI. And be sure to join us next week on Tuesday Talks, when we'll discuss the latest surgical treatments for epilepsy with Dr. Peter Conrad. I'm Mary Ravazio Menard, and on behalf of Dr. Brandmeir and everyone at WVU Medicine, thanks for joining us and putting up with the rain and thunder, and have a great day.